Welcome to the Dr. Masi and Dyl Show. I'm your host, Dylan Loquist.
And I am Dr. Masi Reynolds, orthopedic sports medicine specialist.
I am his trusty sidekick, former medical student, anatomy nerd, and also former patient of Dr. Masi's.
And in this episode, we're talking about the Starr Reickert. Annie is a Maui legend. She is a multifaceted waterwoman and a certified badass. Some of her accomplishments: she is a mainstay out at Jaws. So she's been nominated multiple times for the biggest paddle award out there on the outer reef. At just 16 years old, she became the first woman to ever foil across that 26-mile Kaiwi Channel, which separates Molokai and Oahu. And just recently, she was crowned the champion of the M2O, which is the Molokai to Oahu SUP foil race. That's a 38-mile race across the channel with an impressive time of 2 hours and 27 minutes. As rad as all of that, she is an incredibly gifted artist. She's known for her stunning surfboard designs that often feature an intricate octopus motifs. The detail on her boards are incredible. She does an amazing job of blending artistic talents and athletic prowess, and it makes her a standout figure both in the surfing community and in the art community. She's a legend.
Well, in this episode, we dive into Annie's most recent injury. We unveil the medical decision-making that went behind the diagnosis, treatment, and recovery process for her most recent injury that she sustained while cliff jumping.
Yeah, we go over the injury and we get a chance for you guys to get to know the Annie that we got to know through all of this.
To get to know the human behind the injury.
The human behind the injury, yeah.
Well, without further ado, should we roll the intro?
Let's do it.
What happened to Annie?
So Annie actually didn't hurt herself in the ocean. She was filming a commercial in Montana or Idaho where it required her jumping off a cliff multiple times, and they were videoing it or taking pictures of it. And so this is her jumping off the cliff, of course, and then a kind of a close-up picture of actually the position her arm was in when she landed in that water multiple times, and that's called an abducted position of the shoulder. And so what happened is if we draw the joint itself, so here's the humeral head, here's the glenoid or the socket, our rotator cuff comes over the top, and then we have our AC joint over the top. The biceps comes in, the biceps tendon comes in and inserts at the top of the joint there. And what was happening is the force was coming up as she was landing with her arm out to the side into the joint, shoving her head, her humeral head, up into her labrum at the top where her biceps anchors here, and then also pinching the top portion of her rotator cuff. So she did that over and over and over again.
Ow.
Yeah.
Based on this mechanism of injury, what are you thinking? What's going through your mind? What could be the injury that occurred?
So, I'm lucky to be connected to an incredible group of therapists and athletic trainers, especially out on Maui, where they're able to work with Annie kind of right away. So I had a little bit of idea just based on kind of the information that they provide, but the pure mechanism of the arm coming down like that, we see it sometimes in our climbers, but we see it in patients who are falling with their arm extended. That a lot of times it's tearing of the superior labrum or the labrum in general. So I'm thinking one of two things: either a slap tear, a superior labral tear, or a impingement, potentially rotator cuff pathology.
What's the next step in diagnosing?
So in my world, MRIs are everything. Being able to tell the entire story based on the magnetic resonance imaging is so important for not only myself, but for my athletes and their understanding of their injury.
Can we take a look at the MRI?
Let's look at Annie's MRI.
Wait, before we get into the MRI, I think we should dive into the anatomy of the shoulder labrum, specifically the shoulder joint, so that our audience can know what they're actually looking at on the MRI.
Perfect. Let's go over the anatomy.
Okay, so we have our human anatomical model right here, and we're gonna be looking at the shoulder joint. So let's isolate this. And the shoulder joint, it's a ball and socket joint. The ball being the head of the humerus, which is your arm bone, right? You could see it's a ball shaped. And the socket being the shallow cavity of the scapula called the glenoid fossa. It's kind of like...
I like to think about it like a golf ball sitting on a golf tee, right? A very, very shallow socket with a larger ball, which gives us that full 360-degree range of motion that we enjoy.
And with that range of motion comes, a risk of skeletal stability, right? There's multiple positions that the shoulder could be in that put you at risk for injury.
Yeah. Contrast it to like a hip, right? A hip joint is deep into the socket. So the bony anatomy allows it to be more stable. The shoulder joint, very different. It's naturally unstable. So it relies on the soft tissue structures around the shoulder to give it the stability that we need.
And the body's clever because it makes up for this instability with various supporting structures,
That's exactly right.
starting with, well, these ligaments, right?
Yeah, ligaments. So it's kind of just like this thickening of the capsule as it goes around the shoulder itself.
And under these ligaments, we have the joint capsule itself. And under this joint capsule, we can unveil the shoulder labrum or the glenoid labrum, which is continuous with the long head of the biceps brachii tendon. And Masi, tell me more about the glenoid labrum.
So the labrum is, think about it like the meniscus of the shoulder. So not only does it deepen the socket, so it deepens the socket up to 50%, so it gives it a little bit more stability by making it deeper. It also adds as like a cushion or a supporter. So it's this fibrocartilaginous ring, this cushion of connective tissue that helps provide padding and stability to the joint.
Now that we understand the anatomy of the shoulder joint, let's dive into the MRI.
So here we have Annie's MRI. The first view that we're going to give, just to orient you, is what we call the coronal view. What that means is that Annie is standing and facing us. So this is the outside portion of her left shoulder. Her head would be in that direction and her right shoulder would be over here. This right here is what Dylan was just describing as the humeral head, the ball portion of the joint. And here's the socket, the glenoid portion, or the T, if you will, in the golf ball, golf tee analogy. This is just the supraspinatus, or the rotator cuff that comes over the top, one of the main rotator cuff. There actually is 4 of them, and then you're going to see the AC joint over the top right here. So this is called the coronal, and what we're doing is we're scrolling back and forth from the front all the way to the back of the shoulder. And in this view, we want to take note of what we call the superior labrum, meaning the top portion of that labrum that we just described. The biceps comes in as anchors at the top, and what we're looking at right in this area is to make sure that labrum is continuous with that biceps. It's attached to it, meaning it's all one structure. And if we see fluid or we see white traveling up into that actually labrum, then that, based on criteria that we utilize on an MRI, is indicative of a tear of the labrum.
So we're looking at this MRI and I see a little bit of white right there.
That's exactly right.
Now you're thinking, does this confirm the initial thoughts that you had of what this could possibly be?
It's consistent, right? I mean, the mechanism of injury with the multiple repetitive abducted impact injuries, 1, 2, the way in which Annie had described it, and then her team with Mac and Sam and everyone at Deep to Peak, all coming together to say, hey, this is very consistent. And that's important when we're diagnosing or making a decision is, does the mechanism match the clinical exam? Does that match the symptomatic subjective from the patient? And does the MRI match that? And it's all important when we're talking about managing athletes.
So if you were to diagnose this from here, like what's the next step or what's your diagnosis at this point?
Yeah, so the diagnosis is a variation of what we call a slap tear, a superior labrum anterior to posterior.
What is a slap tear? Can we unfold that a little bit? Is that like a...
Yeah, SLAP. Let's talk about it.
Let's go to the whiteboard. What is a slap tear?
So superior labrum anterior to posterior. Let me just draw the shoulder again as a reminder, right? So the humeral head, this is the socket, right? As it comes around, rotator cuff. The biceps comes in and anchors at the top of the T, if you will, or the socket. So if we take and look at this face on, we have a beautiful drawing of the socket here face on. And the biceps tendon here is coming into the top portion of that socket or that labrum, which we call the superior or the top. So that's the superior component of it. We're talking about the labrum. That's the labrum component of it. And the tear goes from the front to the back. That's anterior to posterior. So a tear at the top of the labrum from the front to the back is a slap tear. And we know that there's, just based on the classifications, thank you, Snyder, that there are actually upwards of 10 types of slap tears, but the 4 main types that we like to talk about are right here.
Yeah, the Snyder classification is these are kind of the 4 most common that you'll tend to see.
That's exactly right.
Why is there 4? Do each of these types present with different patients, different histories? Like how does this happen versus a type 2?
So it's important to, 1, understand what we're looking at based on the MRI and how we can correlate that to what we see intraoperatively if the patient ends up having surgery. Because 1, we want to recognize which tears are actually more problematic and require surgery and which ones hopefully we can avoid surgery with. And so that's pretty much the basis of the classification, is to try to guide us in one way or the other, surgical versus non-surgical, when we're educating our patients. So type 1s are probably our kind of overuse type injuries. So we see them in our throwers, we see them in our paddlers, overhead athletes, volleyball, baseball, etc. So you see it's kind of degenerative over time, wears out that top portion of the labrum, because every time we come over the top, we're pulling on that biceps anchor, and so you can get some debris or some fraying of that labrum right there. 2 is actually when the tear gets into the actual biceps anchor and separates from the top of the glenoid. And so the biceps actually pulls hard enough to separate that superior labrum from the actual bone itself. And that's a pretty common one, and one that we'll talk a little bit more later about. Type 3 has a tear that actually splits through the labrum, and the labrum actually drops into the joint with the biceps anchor kind of intact. In type 4, where the whole thing kind of detaches and acts kind of like a bucket handle as well. And the way they describe that is it kind of flips back and forth and can be quite mechanical for patients, meaning they can feel catching and locking, etc. So,
do any of these, which one's like the hardest to recover from? Does blood supply have an impact on any of this?
I mean, they're all difficult. Like, just in general, anything intra-articular, meaning in the joint, has a difficult time healing because the blood supply is just really poor. So you're absolutely right. And that's the reason why, unfortunately, a lot of times you're seeing patients with labral type tears, and especially high-level athletes end up having them fixed because the blood supply is just not great. And a lot of times we have to go in there and take care of them. So.
Okay, so which type is Annie's? Type 1, 2, 3, 4?
Oh, man. Well, Annie was unique in a sense that based on the imaging and based on the MRI, like we showed you a little bit earlier, radiologists, I think, called it a slight type 2 slap. It did look like it had components of type 2, but maybe it had some element of a type 3 as well, with a little bit of a bucket handle. But it actually wasn't until we were in her shoulder arthroscopically that we were actually able to identify what she was dealing with, which was a Buford complex.
What? Okay, can we dive into that? Can we see what it looked like while you're doing the surgery?
Yeah, let's show you the arthroscopic images. She did have a tear, but it was in association with a Buford complex.
All right, let's pull up that footage.
So here's Annie's shoulder. This is an arthroscopic view looking inside Annie's shoulder joint. So just for orientation's sake here, Annie's on her side. Here is the socket right through here. This is called the glenoid cavity that we talked about earlier, the golf tee component of the joint. And then here's the ball portion of it, so the ball and socket. So as we move around the joint, what you can actually see is that Annie, in addition to tearing the back portion of her labrum, so this is the 12 o'clock position here, and this is the tear over the back, so almost like a posterior superior tear, she had a variation in the front of her shoulder that we see quite rarely, which is called the Buford complex. And what that is that she's actually missing the front portion of that labrum, the anterior superior, the top front portion of that labrum, and it's made up by a thickened, what we call middle glenohumeral ligament, a thickened cord-like structure that adds that stability to the front. So this is a unique variation in the joint that we don't always see. It's actually pretty rare. And in addition to her tear, she had this Buford complex.
Can we dissect this Buford complex? I'm a little confused, and I'm also very interested in what that entails.
Well, let's draw it out first just so you can see what a Buford complex actually looks like.
What is a Buford complex?
All right. Shout out Don Buford down in Texas for classifying this. But a Buford complex, this is our normal anatomy. Biceps tendon coming in, superior glenohumeral ligament, so the top ligament that helps support and add thickness and structure to the joint, the middle, and then the inferior. So this is what our typical or normal anatomy looks like. The difference with the Buford is that they're missing, if we split this labrum into quadrants, the patient is actually missing the top front portion of that labrum that we call the anterior superior labrum. So that's the portion that's missing. And the way that Annie and patients with the Buford complex make up for that stability and make up for that anterior labrum is this thickened cord-like, what we call middle glenohumeral ligament, the MGHL. They still have that superior glenohumeral ligament that comes across here, and then they also still have their inferior glenohumeral ligaments on the bottom. But this is nice and thick, and it helps provide support to the front. Sometimes they have an attachment to the glenoid there, but typically this is what it looks like, and this is what we saw with Annie intraoperatively.
So does this change this anatomical variation? Does it change how you approach the surgery or the treatment?
Good question. And that's honestly why we're even talking about it, right? Because the important thing to recognize, especially in an overhead athlete, is that when you go in there and you see this bare area, you see this empty glenoid, is that your first instinct as a surgeon is to fix it, right? Because it doesn't look normal. And that's the problem I think that luckily generations before me discovered, is that if you try to fix this down, if you try to put stitches in there and hold it down, you're going to over tighten the patient. And as an overhead athlete, that's kind of a death sentence. Like there's no way you can paddle. There's no way you can get up overhead if you end up tightening that middle glenohumeral ligament. So it's important to, one, recognize it, and two, know how to manage those.
All right. Well, that's really interesting.
Yeah.
Right? I think I understand what it looks like here.
Yeah.
But can we take a look at, can we possibly see that?
Yeah.
What it looks like on the surgical level, like real life?
We'll show you arthroscopically what it looks like and what we ended up doing with Annie's shoulder. All right, Dyl, so you wanted to see what it looked like intraoperatively. So here's Annie's shoulder. So again, going back arthroscopically, and I'll go to this position because you'll be able to see everything. For orientation, again, superior labrum right here, you can see some fraying of the labrum. This is that naked anterior superior glenoid right there, meaning the labrum should come up here and you should see the soft tissue come across, but we don't see that. And this right here is that thickened MGHL, that thickened portion that makes up for the empty glenoid or the lack of a labrum. And this is just a connection of that middle glenohumeral ligament to the actual glenoid itself. And we call this area right here the sublabral foramen, or just this open hole that we typically see in the setting of a Buford complex. And like I said, the natural instinct, and typically you want to try to stabilize this front portion of it. And so we've seen where the MGHL will be brought down and fixated to the glenoid over here. And that is, like I said, very problematic for overhead athletes because it over tightens them.
Where are the stitches? I don't see any stitches.
Yeah, so Annie had a unique case in the sense that, one, she had a Buford, but also she had a posterior labral tear. So you can see here anteriorly that MGHL coming down. Here's her biceps coming in over the top and securing itself to the top of the glenoid, continuous with the labrum as it goes around the back. So she had a peel back. So her labrum actually peeled off the bone this direction, and then she had a split tear through it. So she had this interesting variation of a kind of a posterior superior labral tear that we ended up fixing with multiple sutures. I think we ended up doing 3 total suture anchors, really low profile anchors. We did a knotless anchor here and then a tied over the top. And again, this is the important part for us when we talk about the art of medicine, is to have an understanding of what the athlete needs with regards to range of motion and mobility in their shoulder. For me, yeah, you could tighten up this. You could probably put a stitch up there and I'd be just fine. But for Annie, knowing what she does in the water and in life, being able to give her that full range of motion while getting that thing to heal is so important. So we wanted to make sure we do as minimal as possible, get that thing to heal, and give her range of motion she deserves.
Well, and it seems like whatever you did worked, because after this surgery, I mean, just the other month, she was able to go out and win that, take first in the M2O sup foil.
She's
race.
Incredible. Yeah, I can't take credit for that, man. Annie's special. She's different for sure. So although we fixed her, I mean, we do a lot of these, types of repairs. It's, to me, it's what the patient, who the patient is in the recovery, their commitment to the rehabilitation, the team that they surround themselves with. That's it, man. 20% is what I do. 80% is the human and the work that they do on the tail end of it. And Annie's just different.
So why are we even talking about Annie? How is she special? Was there anything that you noticed throughout her case that like shown that special?
Annie's special beyond her Buford complex. She's, we had a lot of amazing conversations facilitated through Sam and Mac over at Deep to Peak. And she has this, I'd call it this somatic awareness, this ability to understand what's happening to her body at the most mechanical levels. She's able to describe, things that I had never heard athletes describe with regards to their shoulder. And so she knew what was going on well before MRI, well before I got in there and saw things. And then her ability to be able to kind of communicate that to me and her team, was incredible. And it really did change, the outcome. She just, she's special. So.
How did she describe, like what words did she use? How did she describe what her body was feeling?
Yeah, I mean, she used the term, it's speaking to me or talking to me. It's sticky here, kind of, et cetera. And not so much the language, and that was the important part of it, but her ability to know kind of where those boundaries are as far as what she, could tolerate, what she couldn't tolerate, when she should push, when she should pull back. Just was very in tune with her body. And I think that a lot of that is because, of just who she is in general, not just the athlete identity kind of component of her, but just the whole Starr Reickert component of her, right?
Yeah.
The artist in her, I guess.
Yeah. Does it help when patients communicate these things to you? Does it change how you approach just the whole medical decision making?
Yeah. I mean, one, obviously she did incredible job of building a medical team around her. And that's so important. And not that I don't trust athletes, but to be able, especially if I'm dealing with remote athletes, to be able to have open communication and trust in not only her, but also the team that she has built for her, but also just trusting her and knowing, okay, this is too much, this is too little, this feels like this, kind of, et cetera. And it's like, a lot of patients, we're not going into surgery or we're doing different things trying to lead up to a procedure. If I don't quite trust necessarily what the patient has done beforehand or what they're saying to me. So, yeah.
Oh, well, how does someone learn this ability to communicate like what they're feeling? Is it learned or is it innate?
I think a combination of both, really. I think that most athletes do have this innate somatic awareness, if you will, this ability to kind of communicate what they're feeling. Some just kind of want to block it off and don't even want to know. I think it's a combination. I think that the talents that she has cultivated and developed outside of the ocean physically, I think have allowed her to reframe how she kind of both kind of feels, if you will, but also how she describes and how she communicates, and also just her entire approach to her injury and her recovery. I think that she's done an incredible job of building talents outside of her physical talents in the water.
Yeah, I mean, and we could see those talents in just the awesome artistry. We could check out her Instagram, and she has just a whole plethora of just really cool designs on these surfboards.
It's amazing.
Yeah. How important is having, you've touched on it a few times, but like how important is having something to have like an identity outside of your sport or in Annie's case, the water, to go back to be able to express yourself. Yeah. How important is that in the recovery process?
Yeah. I think selfishly it's important for me because I don't have an athlete who's just frothing to get back all the time, right? Like that's, as much as I enjoy trying to get athletes back fast, it's always difficult when we're up against a clock and up against the timeline. And so again, selfishly, it's important, but for them and their ability to be patient through the recovery and to be able to find things that fulfill them outside of their sport or their the physical aspect of what they're doing. So I think it's instrumental. I think for her, she was patient, she understood the process, she trusted the process, and she wasn't in a hurry. Right? She had other things. She had her she was. I mean, I don't know if you followed during Instagram, but the amount of boards that she got done and things that she was doing was so incredible. And I never felt, as much as all athletes want to get back, I never felt it in her that she was going to push beyond what her body was ready for. And I think that that's so important in the recovery process. And the meditative aspect of just knowing your body's going to heal, being confident in that, trusting that process, all the while not putting the stress on the body and the mind to make something happen faster than it needs to.
Well, everything that you're saying reminds me of something I learned when I was in medical school, the mind, body, and spirit component of healing. The body has its own time schedule of healing. Yeah. And it's important. The mind can help the body. And that's why it's so important to have other things to tend the mind to.
That's exactly right. And that's why it's so important for patients like Annie. And she came in well educated on her pathology and the treatment options is to be able to embody it, to be able to envision it, and to be able to know what's actually happening to your body. And I think that manifests in healing too. So.
Well, you weren't kidding when you said Annie was unique. Yeah. She is a special human. Yeah. And any closing words?
Yeah, no, I thank you, Annie, for allowing us to be kind of part of your recovery journey. Thank you for allowing us to share your journey. Stoked on you and your recovery. Congratulations on the M2O, and excited to see you out in the water.
Yeah, and we will see you guys in the next episode of Dr. Masi and Dyl. Comment below anything you want to see us touch on in future episodes, or if you just want to say hi. And I guess we'll see you
in
the next one. Thank you, guys.